This is a case that I hope you will never forget. So everybody's going to get this case regardless of whether they responded to me or not. So this is a 70-year-old lady that had some right upper abdominal pain. She had some renal pelvic dilatation, a suggestion of UPJ on one side. Part of the workup, they did a colonoscopy, and there was a 6-millimeter colon polyp that they biopsied, and that is what the slide was of. It was from that transverse colon biopsy. So here's the tissue that I had, and as you can see, there are two pieces of tissue on the slide. The lower one has the appearance of a tubular adenoma. It's about the same size as what was seen grossly, or at the time of colonoscopy. The other one is a malignant tumor, high grade, very infiltrative. There's no residual colon mucosa on that piece of tissue. It would be helpful to have that, but there's not. And you don't always see residual, colon mucosa on a large cancer. Here's a higher power showing a very poorly differentiated neoplasm. There's a suggestion of a keratin differentiation. So my impulse was to say that this is transitional carcinoma. It's not uncommon to see transitional carcinoma with squamous differentiation, but it really doesn't make sense because there was nothing, there was no mass in that bowel. So I thought about this a little bit more before I pulled the trigger. And I told them, I said, listen, did you have any other tissue in the run that day that looked like this? And they said no. And I said, well, you guys recently moved your histology lab to a central location, so you've got multiple hospitals feeding that lab, and you really need to look at that run that came through the lab that day from all the hospitals before you can say that this belongs to the patient. So they called me back a couple hours later. I said, it's going to be at the embedding station. And sure enough, at the time of embedding, there was something next to this case. So here's a higher power that shows the squamous differentiation. One of my goals of sharing these cases with you is to have everybody respond to one case at least once during the year. I've not attained that goal yet. A goal of mine was not to have everybody missed the case. So everybody got the diagnosis of cancer, but you made the cancer diagnosis on the wrong patient. So basically, the final diagnosis should be tubular adenoma, and the tissue on the slide is extenuous from another case. And we actually did genetic testing on the two pieces of tissue and proved that these two pieces of tissue on the slide came from a different patient. So here's the slide again showing these two different pieces of tissue. The gross description said there were two pieces of tissue, so the gross description can often be helpful in these situations, but it was not helpful in this particular situation. And you can see to the left there's another piece of extraneous tissue. That's a bath floater, and that was between all the ribbons of tissue on the slide. So here's the squamous carcinoma. It was a squamous carcinoma of the face, and you can see that there's a fairly poorly differentiated squamous carcinoma, but there are areas of recognizable squamous differentiation. There's a nice keratinized cell centrally there. And this just shows a very similar look to what we had on that piece of tissue. And I'm in the process now of proving that this piece of tissue belongs to the piece of tissue in the block. This is from case 6 last year, which was a floater, which many missed last year, so you may want to take a look at that. So the rate of floaters varies in every practice, and it depends on whether you do this in a retrospective review or in a prospective review. But I would say for slides, it's probably 1 to maybe as high as 4%. And we've worked on some things in our practice to decrease the number of floaters in our practice. I think you should look at this slide. 90% of the floaters are from the pathology lab. So, sometimes you'll get contamination, from the surgical suite, or I've seen cases where they put tissue in a bottle from 2 different patients in a bottle. That does happen, but the vast majority of floaters, we own it. And so we need to be the ones that solve it. They're usually not a problem when they're way away from the tissue, but you can see that almost half are near the diagnostic tissue. So particularly in small biopsies, it becomes a real issue to recognize. Malignant floaters are obviously a big problem. Benign floaters maybe not so much, but about 10% or so are malignant floaters. The lab in this review, which has probably changed a lot since 1998 or 1996, because I think we've got more PAs in the practice out in these other facilities. But back in the day, pathologists were doing most of the grossing, and you can see that they were the more common cause for floaters.